Hello and welcome back again for a new episode of the Pain Podcast. My name is Bart from Buchem. I'm a Spain specialist physiotherapist. I'm from the Netherlands and I'm welcoming you again for quite exciting announcement to be made. Actually, if you haven't heard about it, we have Jo Nijs or Jo Nijs invited for a science session in January. So this episode will be sort of a bit of a prelude. With me is Timmy Beams, a friend and founder of Le Pub Scientifique, and therefore we will just probably gonna share our thoughts on, especially the classification of pain and terminology around nociplastic pain. Which is a big debate, which is ongoing and probably will go forever. It will be exciting. So good to have you again on this cool podcast, Timmy. So I think we're just gonna run from here, right? Is that all right?
Yeah.
Cool.
Absolutely.
So just to give you a bit of an introduction on the topic for today, I just want to sort of give you a bit of a little context, right? So nociplastic pain is being introduced by the IASP in 2017, if I'm correct. And it's a so-called the third mechanistic pain descriptor, alongside nociceptive and neuropathic pain. And it's defined, just to stick with the definition, which could be a bit boring, but I think it's quite important here. So it is defined as pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of a peripheral nociceptors, or evidence for disease or lesion in the somatosensory system causing the pain. Wow, you can. That's the great thing of podcasts. You can go back and replay this bit if you like. There are many references. Having Jo Nijs in our science session in January, he is part of a task force alongside Eva Kozak, who's another big name in the field, as appointed to sort of creating clinical criteria which affect you as a clinician, which will also affect you as a patient, which will be interesting. So this is one of those perspectives we want to cover today. Maybe just let's go with this definition, Tim, and this whole thing about nociplastic pain. Any initial thoughts on this, just to sort of how do you feel like this is important or makes any sense to you from your perspective as a clinician?
Yeah. Cool. So, well, I mean, I think it was important in that before the definition was proposed, we were always thinking, like, it's one way of thinking about pain, isn't it? A mechanistic understanding of pain, very much sort of driven from a pharmacotherapy point of view as well. So understanding the mechanisms, and by understanding the mechanisms, we might be able to either activate or interrupt them in some sort of way. So it's, you know, you can understand that as one perspective. And what we understood before that was we had these sort of clear delineations of nociceptive pain, which was due to actual potential tissue damage, or that's how we used to refer to it, didn't we? And then the nerve-related pain, which was neuropathic. And I think they're sort of fairly familiar terms for many people. In fact, most of my patients will have heard of neuropathic, not so much nociceptive, but certainly neuropathic. And at the, you know, previous to the definition, the nociplastic definition, we then had other ways of saying, well, we think there are central contributions. We think there are contributions that are not related or not confined to either the nociceptive and the neuropathic definitions. And there were many different ways of thinking about that. Some people sort of went down the route of talking about central sensitization. I know Jo Nijs certainly was interested in that side of things. And then other people went down slightly other routes as well. So people talked about representational change, brain change, etc., engrams, neurosignatures, etc. So that, like, there was a whole, but they didn't very easily or tightly fit to this nociceptive neuropathic and now nociplastic definition. So I think it was a sort of inevitable and important step. Was the first thing to say. However, let's sort of talk about the strengths, because if we have a clear definition, we theoretically should be able to profile people based on those definitions as well, shouldn't we? So we should be able to do a fairly good workup and diagnose whether there is evidence of one or other of those pains present. My reservations still, and I remember debating this like when it first came out, like seven years ago. I remember doing some podcasts with Ben Cormack at the time and talking about this. But there is a problem in that we still can't clearly define what nociplastic is. I know it tripped off your tongue, Bart. Didn't it? But it's essentially changes that we can't attribute to either tissue damage or potential tissue damage and nerve-related damage. So it's some sort of central change, whatever central means, which I think is problematic. And I think it's problematic for a few different reasons. I think it's problematic because it still fragments, that you have this clear, you either have or you do not have this thing. But in the clinic, it's messier than that, isn't it? And I think
I could agree. I couldn't agree more. It's messier. And
it's so compelling, isn't it, as a researcher and as research groups, and I'm thinking about this at the moment as well, how we profile certain pain conditions, because if we could profile them well, then it does a huge amount to being able to then identify what the best care might be for that person. So what a high value intervention might look like, and be able to identify those. It would do a really good job for that person to say, I've been diagnosed with this pain, this is what it is, these are the things that I can do about it. So you can see where it might have massive merit as both a provider and also a patient as well. I personally am sat firmly on the fence where I can see like challenges and the merits as well of a definition.
So if it's about why would it matter, right? I think from a scientific perspective, you would say any researcher would love to be having a more homogenic, let's say, group, because it will be easier to make any generalization of your results. Whether chronic pain groups, they're massively different, right? That you can see I would say that any person who's treating pain would absolutely agree that no person is the same. There's no pain is not the same. It's so much different, but it's very hard to classify it on whether it's depending on where you sit, right? Whether you feel like, is this person at the right place and time with you? So my question will be, and I'm really keen to hear your thoughts on that. So how could classification possibly drive your treatment?
Treatment,
and your decisions. How does it affect in the end what you do, what the program or the treatment look like, apart from diagnosing? Because you can have a diagnosis and you say, well, if the research is like it doesn't matter because it's still the same. But if it's not the same, why would it matter? And why would it matter to you to classify between person 1 and 2 by using any kind of classification. If it's a mechanistic descriptor, that's fine. But how could it possibly help?
Yeah.
Or
yeah.
what if it already changed in your clinic?
Yeah. I mean, I'm sure it has definitely changed my clinical practice. Like, I can remember, I'm not necessarily the day, but I can certainly remember the first times that I was introduced to terms like nociception and nociceptive pain and neuropathic pain and things, and that utterly transformed my interest and understanding of pain, and drove where I started to search for information and understand people. So it definitely will have shaped it. Do you know what? I had a really interesting conversation, and it was this was yesterday, and it was almost asking the same question as you just asked. And in my clinical practice, I put a lot of effort into trying not to fall into a trap. So essentially, I try and create as much of what I would call like free form thinking. So some sort of interactive clinical work between me and my patient, where, yes, we're mindful of diagnoses, but it's not limiting us. So, if I hear someone say, I've been diagnosed with nociplastic pain, or I haven't had a diagnosis, and I'm thinking we might be able to do a better job of a diagnosis, I don't jump in and go, oh, do you know you've got nociplastic pain, or you've got the signs and the symptoms that would suggest that you've got nociplastic pain? I would be a bit more inviting about it. Before we came on, we were talking about, I haven't had anybody come to my clinic and say, I've been diagnosed with nociplastic pain. Have you?
Well, others similar, but it will be central sensitization, for example. But that term obviously has been there around for a while.
Yeah.
So, and I know there are some, let's say, doctors who would describe it as such.
Exactly what I get. I've had patients who will come to me and say, I've been told I've got central sensitization. It's a bit not quite as common as I've been told I've got chronic pain. And then very, very recently, I've been coming across the term, I've been told I've got neuroplastic pain, which is, I mean, it's essentially a made up definition for pain, isn't it? But would mean there's some evidence of neuroplasticity being structural, functional, which is absolutely going to be a part of pain. But it certainly doesn't give us a strong foundation to understand from a profiling point of view, like, well, okay, given that there's evidence of plasticity, what does that do for our treatment of choice?
Yeah, totally. No, that's what I can relate to, like most of the patient will be definitely say something like, I got pain, it doesn't go away, and it's there for long, so it will be more like chronic. Like chronic pain is in my clinic will be the most common, let's say, wording. Although some people say, well, is it really chronic? They still consider it as a temporary condition, because they're sort of seeking for this magical fix, if you like.
Yeah.
Otherwise, people do get obviously they understand and they feel like it's not gonna disappear suddenly, but there is this hope, and therefore there is a descriptor will be merely, I would say, from a patient point of view, because that's where we are now. I would always sort of ask people if they need a diagnosis, whether that will be helpful for them, and I think we can be quite frank about that. So actually there are debates and discussions about how should we call it, and probably there's no one descriptor that will cover everything. But the same thing happened with chronic fatigue syndrome, because there's still people feel more comfortable with the ME descriptor, and others with this CFS will be. And the word syndrome sometimes also has a magical context, whether it's something, right? So it's all about acknowledgement, I guess. And when people are seeking for acknowledgement for whatever reason, a descriptor could be helpful to some degree, but there's also a downside of it because it doesn't tell you necessarily what it is, and it's not necessarily what people feel. So I would be very cautious with bringing any type of label, which is basically a metaphor. In a way.
Yeah, I think you're right, but there would be a merit as well, because if you're able to give a clear diagnosis, it could also do a good job of validating an experience that otherwise might have been really troubling and difficult to understand, and troubling and difficult for someone to communicate to their, immediate network as well, to their family and friends and work. And so being able to diagnose something also has huge merit.
Interestingly, so in Australia, Lorimer Mosley and his group has done some interesting research, and they've been basically have been asking the consumer from a marketing perspective. So what should we call it? And consumers has, for example, they didn't favor nociplastic pain, and there was basically another made up term was pain system hypersensitivity as an alternative, which was favored by Australian people in chronic pain, which is interesting because it may not work for people in the UK, and it may not, like a direct translation may not favor for Dutch patients as well. So translated, it doesn't really make sense because it's too much words. But you can see we have to be very in translating these, or you have to ask the consumers as well, or at least you should starting the conversation where how would be what would be helping you to acknowledge and feeling comfortable with what type of term. And I think we should not sort of being too much sort of sitting on top of what we want, or we should not sort of proclaim that we are the truth and this is the right term. I think that would be very depending on where you are, where you're working with, and cultural aspects will come in place as well.
Totally, yeah. There's, although like you said, they're sort of, yes, they're made up terms, but they have some element of sort of a known entity around them as well. So hypersensitivity sort of immediately evokes something in someone, that there's
something has changed. Yeah.
It creates a bit of an understanding in them. And it probably does a pretty good job, even though that's like a made up term, it probably does a really good job of describing what it is that they're experiencing as well. So why don't we just use what someone feels best describes what it is that they're experiencing? Can I say a few, because I'm pretty biased. I am completely biased position, because everybody that I see have long-term pain problems. So I see people where it isn't. I'd love it to be where there's this sort of really clear, predictable relationship of pain and damage, and so. But what I see so often is that when I'm listening to someone and they're explaining it, I'm seeing such a huge mixture of pain. And if I'm just like thinking back to people that I spoke to even yesterday, like their people describe pain in multiple sites, for instance. So it often, yes, they come and they tell you about this one area, but actually when you start learning about them, there are a number of other things. So I'm thinking about a guy that I was treating, and it transpires that he's got headaches and irritable bowel syndrome and back pain and pelvic pain, and but that's not uncommon. But it shows the complexity then of of pain, doesn't it? And coming back to this idea of nociplastic pain, that can be a really helpful tag and diagnosis to understand, instead of when we're trying to get a sense and an understanding of someone, instead of us focusing down and down and down and being too sort of myopic, actually it's important, if we're thinking at a mechanistic level, and nociplastic is part of those mechanisms, is to broaden our perspective and is to say, let's ask about the whole person, because actually having multiple sites might start to move us in one area, or having other systems involved might start to move us in a particular direction that will help with your diagnosis and then your treatment. So yeah, there's definitely value. Although, as I'm saying those things, I'm also mindful that I don't know for sure whether those are good ways of ruling in or ruling out nociplastic pain still.
Yeah, I agree, and that will be the uncertainty that lies and we haven't even mentioned the overlay that it may have. And I think the authors of these let's say the authors of the task group force will be acknowledging there will be overlap. So people with let's say and what be neuropathic pain will also immediately have, well, let's say signs and symptoms that also happen in nociplastic pain, if it would be the case. But it will be more dominantly, but it always feels like it's hard when it's like 50-50. How do you decide what you want to call it? Like the challenge will be from a clinical point of view, and I think that will be one of the reasons why this is happening, is that it would be helpful if clinicians, let's say from a very mechanical background, that we as a profession, but also as a whole healthcare system, we should acknowledge that things like nociplastic pain happen anyway. It's something more than just the tissues. We also have to consider therapies that include, let's say, brain targeted functions, if you like, or psychology based stuff. And we have to and the earlier we get on with identifying this, is also basically ruling out the first, because we seem to be quite, well, I would say effective and quite, well, I would say confident in treating people, or know what to do with people with a very dominant nociceptive driver, and also with a driver that sort of sits in the peripheral nerves. Doesn't say we can do it well, but we seem to know what we have to do. Apart from when we don't feel like it doesn't add up, right? These symptoms I can't rule out or include, and therefore people, I don't know what it is, just find another doctor. And I think this is something what has to stop. Yeah. And I know from my experience with talking to Jo Nijs and hearing Eva Kozak, and the IS movement is saying, well, we have to do something, because this is the majority of patients with ongoing pain. And we can't say we treat pain, but not the pain we don't understand. And this descriptor should also help to create an understanding with clinicians and to push them towards, like, let's start offering what people need, right? And what we know from the research can be more beneficial than sticking with very expensive imaging and expensive clinical and diagnosis routes that people are getting stuck in, because it's very unlikely that we'll find that biomarker on the short term. So therefore, I can see the merit of doing this, that a lot of therapists never consider or don't feel like they're comfortable or can actually offer anything for people when it's not nociceptive or it's not neuropathic. And that's absolute, that should change, right? And if a descriptor would be helpful there, I can see the merit of it.
Yeah, totally. Yeah. As you're talking, I'm just thinking of a couple of patients just this week where the treating physician clearly hasn't quite, it would be really helpful if they were up with this, where one example is that this person has gone through rounds and rounds and rounds of antibiotics, and they're saying, well, it's still, yes, there's no evidence of an infection or infection markers, but you've still got the pain, so let's keep going with this because this is the route that I know. I'm thinking there's infection there. And then I can think of another patient whose treating physician is thinking this is neuropathic pain, and they've been prescribed drugs that you would expect them to be prescribed if they've got evidence of neuropathic pain, and the message that this patient got was, well, let's try this for 6 months. and then let's see whether we'll know whether it's effective but that, to me, that is exactly what you're saying. Let's know now. Not let's try. And yes, drugs might be a way of actually being able to build evidence of the ruling in or ruling out process of a diagnosis, but not like let's just try things out like willy-nilly for months and months and months or years before we decide, well, that, maybe it's something different to what we thought it was.
Yeah, and
isn't nerve-related pain. Maybe it isn't like an inflammatory process that we're not able to treat.
Yeah, but let's try to widen up the scope and don't allow us to stick with the original. If we don't understand it, there is so much more that actually we can be helpful. I also see what role, and it also expands your role as a therapist or as a doctor to identify psychological problems, if you like, and another debate will be how much does this depression or anxiety relates to the pain experience. It's not necessarily you treating it because you're trying to treat the anxiety of the depression, but it's probably something you have to understand or being aware of because it makes sense to the patient. It makes a difference to the patient. If you don't have any clue about it, you're probably just gonna miss out for things, and it's gonna be, you won't get this relationship. You won't be as helpful as you could be if you actually do know about this stuff. And basically on 100% of the cases in my patient caseload will be, if they describe their GP as a positive, like a reinforcing and engaging person, they will be say, well, because he listens to me or she listens to me, it understands the whole situation, and it sort of makes sense that I'm here with this therapist who also taking psychology-based therapeutic approaches, which never gives any pushback. So it's interesting how that could work. And if your GP is not in that area, I can see that they're missing a lot. And it doesn't necessarily going to be helpful, but not necessarily just going to mean it's a bad doctor because they're doing their job. But I think for the result in this type of ongoing complex pain states, I'm pretty sure that we can do much better if we do have that time and we spend it a bit. But that's challenging.
Totally.
Yeah.
Yeah.
Cool. Any thoughts on what you think Jo is going to mention from your perspective, Tim? What do you feel like? What do you think Jo is going to bring in this upcoming science session?
I think he's going to bring a good debate. I think he's going to bring I've known Jo for a long time now, so I think he's grown in his knowledge and understanding, and you can see that in the research as well. So yeah, I'm excited to hear like a balanced perspective. So he's a knowledgeable guy as well, isn't he? And he's done some. I would say, some absolutely integral work in this area. So yeah, super, super excited to hear it.
Yeah, totally. No, I see that the same as they also been including consumers in their work, and there's a lot of debate been going. It's there for years, and so I think he's very excited to have him to give that all these considerations that have been part of this classification or this descriptor, and therefore it's good there will be pushback, because it is basically testing your hypothesis, and Jo, as I know him, is a scientifically ethical person who really wants to be challenged. Like, give me reasons for not doing this right, or so just to adapt and to change it, whatever we need. So this will be an exciting session for sure in January. You got the exact date, Tim? I'm just checking. Oh yeah, I got it. The 23rd of January will be European evening, 7:30 UK, 8:30 on the other side of the sea, right? So it will be 8:30 Amsterdam, 7:30 UK. So, and if you're in Australia, we know we've got a lot of people tuning in from Oz. It will be your afternoon, evening. It will be a lovely way to join us with a Pinot or anything else. So looking forward to hang out with you again with this exciting session. So I think this is for now.
Cool.
All good. Just want to make sure that you, if you got any questions or just reach out to us. We're also always happy to get some ideas. I think we have sort of covered what you can expect in Jo Nijs' session. So there will be a lovely way to basically getting excited about this again. For us, we're also heading to Christmas and New Year's, so we have a bit of time off. And in the meantime, we'll let us know. There will be some free guides available. Check out the website. We're constantly working on this, so it's definitely worthwhile checking out the website lepupscientifique.com, because lots of crazy stuff is going on there, which you can use straight into the clinic and will improve your outcomes for sure. So thank you for hanging in again, and we'll meet again, Tim, for another session.
Thanks very much.
Thank you so much. All right, ciao. Bye-bye.